Good morning, guys. This is Professor Diane Anderson. How are you today? And this is NCLEX session part 5. A little bit about me. I've been a nurse for over 20 years. My main area is critical care. I do psych, I do pediatrics, OBGYN, telemetry, which is also called PCU. I do IMC, I do MICU, SICU, which are also variations of critical care. MICU is medical ICU. SICU is surgical ICU. I also do neuro ICU. As also sometimes I also do cardiovascular ICU for patients with heart transplants, etc. So I've kind of done a little bit of everything, and there's more detail about my history in my field. More on sessions part 2, 3, and 4. So I won't go into a whole lot of detail and kill a lot of time. Let's get right into these questions. I kept it really simplistic today. Instead of giving you a lot of stuff that's real critical thinking, I have some simplistic questions that you still need to know the answers to thrive in your field and to better understand what you're doing and to be able to explain to patients if a patient asks you what's going on with their care, with the medicines they're taking, et cetera, because the doctor usually is not in the room long enough to answer all the questions the patient may have. Or what I've seen throughout the years is when the doctor is in there long enough and the patient tells me, oh yeah, I'm going to ask the doctor X, Y, and Z, I come into the room and they're like, well, I really didn't want to bother the doctor. So I'm going to ask you X, Y, and Z. And I don't know why they get this kind of complex where they're afraid they feel intimidated by their doctor, or they feel like they may be wasting his time, forgetting the fact that when the patient is in the hospital, they are paying a service. It's not like it's free. I mean, if you're in the ER and you're, low income, the ER, legally, we cannot charge you. If that's something you didn't know, you know it now. And for my years of working in the ER as well. We don't turn around anyone. It's illegal to turn down anyone from care if they're coming into the ER. Admitting you, that's a whole other story. But caring for you in the ER and then releasing you back out is covered even if you don't have the funds for care. So we have a lot of people and homeless people that come in who don't have the money and they don't have the insurance. And we don't say, forget you. No, we bring them in, we treat them for whatever issues they may have. And if it's something serious where we have to admit them, we do. And a lot of times the hospital really literally eats the cost of the patient's care that the patient can't afford. So if you didn't know that, you know that now. But a lot of times patients who are in the hospital who are paying customers, whether they're paying or not, they really should feel comfortable asking the doctor questions. A lot of them don't feel comfortable, and they'll even tell the nurse so. And I don't know why they feel intimidated, but some of them do. So you're going to be in a situation where you're going to be answering a lot of questions a lot of the time, whether you want to or not, because the patients get scared to ask their doctor for whatever reason. Okay, so let's just get into this. The first question is, which symptom is an adverse effect of the drug cyclosporine? Is it nausea? Is it B, acne? Is it C, sweating? Or is it D, hyperkalemia? Give it some thought. Okay, if you answered B, acne, you are correct. Now, acne is a common adverse effect of the drug cyclosporine. Now, cyclosporine is a immunosuppressive medication, and we use it to prevent organ rejection in transplant recipients and to treat various autoimmune conditions such as psoriasis and rheumatoid arthritis, which you're going to see a lot in a hospital. Now, however, one of the side effects is the development of acne, or if you already have acne issues, it will cause an exacerbation of your existing acne. Question number 2. What is the function of pancreatic lipase. Now with this question, I want you to just think about it. I'm not giving you choices A through D. Just try to remember, what did you learn in school? What is the function? First of all, what's lipase, period? Okay. We already know anything that ends in ACE. ASE is an enzyme. That's part of the giveaway right there. We're looking at an enzyme. Okay. All right. So the answer is the function of pancreatic lipase is to break down dietary fats or lipids into similar components for absorption and digestion in the small intestines. Pancreatic lipase is an enzyme secreted by the pancreas and is one of the key digestive enzymes responsible for lipid digestion. And a great way to remember your enzymes, especially this one in particular, when you think of, remember, enzyme is, the whole purpose of an enzyme is to break down something, to break it down, okay? So if you're breaking down fats, fat is a lipid. So therefore, if you see lipase, you know that's saying the breaking down of lipids. So it's an enzyme that breaks down lipids. Very, very easy, okay? This question I had to include because you're going to see all different types of abuse in many situations in the hospital settings. Sometimes, unfortunately, it is a coworker abusing another coworker, a coworker abusing a patient abusing the nurse or the doctor, the patient abusing their own family member that's visiting, a visitor that's abusing their own family member if they're supposed to be coming to visit. So I've kind of seen all of this. Oh my God. Not that that's a good thing, but I've seen it and had to report it and was involved in some of this stuff in terms of, getting security involved in protecting a patient from their own family member. It's wild. I mean, like I said, nursing is more than just patient care. You're some of everyone. You wear multiple hats. So this question states the type of abuse that involves intimidating, ridiculing, or degrading someone. What is that called? Again, intimidating, ridiculing, or degrading someone. Is it psychological abuse, sexual abuse, physical abuse, or cyber stalking? If you guessed B, psychological abuse, you are correct. Psychological abuse can occur in various relationships, such as an intimate partnership. It can be a parent-child relationship. It could be a friendship. Definitely workplace dynamics, and even more. Okay, so the effects of psychological abuse can be long-lasting. It includes anxiety, depression, low self-esteem, and post-traumatic stress disorder. And it even can include other psychological issues. Now, guys, it can be challenging for victims to recognize psychological abuse because it lacks physical evidence, but seeking support from trusted friends and family members, a therapist, or even a counselor, especially if you're in a school setting, a counselor will be someone good to see about this. It can be crucial in breaking the cycle and beginning the healing process. So if you or someone you know is experiencing psychological abuse, consider reaching out to a professional for assistance and guidance. And of course, if you see it in a hospital setting and you are the nurse, report it immediately to your upline, which would be your manager. If your manager is not available, then definitely HR. Very important. And that's whether you're seeing it from a family member, causing abuse to their loved one that they're supposed to be visiting because they supposedly care, but yet they're treating them this kind of way. or if it's a coworker, treating another coworker a certain way. So yeah, definitely go up to your upline, which would be your manager, your HR director, chief nursing officer, etc. Or even just your, the basic charge nurse would be probably the first person you want to report it to if that person is available at that time. Okay? Okay, next question. Which of the following would not be considered physical abuse? Is it A, holding a victim down? B, throwing things at a victim? C, threatening to harm a victim's child? Or D, assaulting a victim with a weapon? So the answer is B. Threatening to harm a victim's child is not considered physical abuse. You may ask, why in the world is she asking us this question? Because like I said, I've seen a lot of stuff in the hospital. And in terms of threatening to harm a victim's child, you'll see that a lot. We have some of the psychiatric patients who may be schizophrenic, may possibly have some bipolar going on, multiple personality disorder, etc. So many different categories. It's a lot of behavioral health issues in the world because so many people have been through so many things which create the behavioral health issues and diagnosis because of what they've gone through in their life or what they're currently going through, or sometimes it's hereditary. But the point is, I've had this happen, and I've seen this happen to other nurses where the patient is upset about something the doctor said or something their family member said, or upset about not getting more particular medication that they are requesting that they may be on the verge of trying to abuse or whatever. And they may just literally just threaten, well, when I get out of here, I'm going to hurt your kid and I'm going to do this and I'm going to do that. Yeah. Now, can you really do something about that? Not particularly, especially if they have behavioral health issues. More than likely, most of the time, they don't even know where you live. But they're saying all different kinds of things. But it is a form of abuse, regardless, and you need to be aware and knowledgeable of that. It is not physical abuse. Yeah. But what this would categorize as would be psychological abuse and emotional abuse. With psychological abuse, threatening to harm a victim's child is a form of psychological abuse because it uses fear and intimidation to control and manipulate the victim. Okay. The threat instills a sense of helplessness, anxiety, and vulnerability in the victim, causing them emotional distress. Now, granted, you may not feel this way in a healthcare setting because you're the nurse, and more than likely the person that's causing this abuse doesn't even have your address. So you may not be really concerned. But what if you are, let's say you're not a nurse. Let's just say you're someone listening to this video and you're going through something like this. You have a loved one or a boyfriend or a neighbor or whomever, and they're making comments like that. That's not cool, because especially if you believe them, you really believe them, that will instill a sense of helplessness and anxiety, vulnerability, and emotional distress. And that really should be reported. That situation you document, just like we would do in the nursing situation, we document everything. They have a thing in nursing where we say, if it wasn't documented, it wasn't done. Actually, that should apply to doctors as well. I think it applies to everyone in healthcare. If it wasn't documented, then it was never done, never took place. Because you got to have documentation, it's a legal thing. So even if you're not a nurse and you are going through this in your personal life, document it, okay? Keep track of how often this happens and who's causing it and who's saying what and what time of day, what day of the week it was, etc. Yeah. This also is a form of emotional abuse. This type of threat also qualifies as that type of abuse because it targets the victim's emotional well-being and mental health. Emotional abuse involves intentionally causing emotional pain, distress, or anguish to the victim. And again, this can also lead to long-lasting psychological scars. You want to be aware of these things so you know what your patient is up against, what you are up against, what your loved ones, neighbors, whomever is up against, and recognize it so that you can help another person out and give them the right advice. Okay, next question. What is the true purpose of bedside shift reporting, and why is it so important? Okay, guys, so this is really, really important, and you're going to see this no matter what facility you work in. And you're going to have some coworkers be against wanting to do bedside shift reporting because they may be in a hurry or rush to go home. And I understand, just like when I get off or when you get off or when they get off, all of us are eager to get home. We've had a long day, okay? But it's really important to do that bedside shift reporting, okay? So bedside shift reporting involves the nurses obtaining patient updates from the other nurse or from their peer directly at the patient's side. What do I mean by that? I mean, going into the patient's room, you're literally at the patient's bedside. You're standing right beside the bed. The patient's right there, you're right there. And you're receiving report from the previous shift and documenting and taking notes, etc. Okay? This also encourages the patients to input what they want to say. They might say, you know what, I had a really bad day. I really should have actually had pain medication that you told me I could ask for a couple hours ago. I'm having a lot of pain right now. Is it any way possible I can get that from you? And that way the nurse that's leaving, she can say, okay, well, Diane's taking over here. And I can say, okay, no problem. I'm going to let her finish giving a report and let her go. And then I will take over from here and I will make sure I get you that pain med. What is your pain on a scale of 1 to 10? You see what I'm saying? Because sometimes the patient isn't really saying everything that needs to be said during that current shift. And this gives them time to kind of give their little input or ask certain questions about up and coming procedures or whatever it is that's happening in their life. Okay? And you think about it, it's a whole group effort. It's the nurse that's oncoming, which may be me, the nurse that's going home, which may be Suzette or Mike or whoever it is. And then, of course, the patient, it's their care, and they have their chance to put their input and spiel on what's being said. Okay? So again, it enhances communication. It uncovers disparities in the patient's perspective or care details. Like, for example, the nurse may have just told me, the patient hasn't been in any pain. They haven't asked me for pain medication all day. And the patient's jumping in there saying, well, I was going to ask you for it about 2 hours ago. I looked out the door and it looks like you were running around so much. You look so busy. I didn't really want to bother you, but I'm in excruciating pain. My pain is a 9 out of 10. Okay. So there we go. Just uncovered the disparity right there. Okay, she said one thing, the patient's saying something else. But of course, she didn't know that because the patient didn't inform her. So again, bedside shift reporting helps uncover a lot of stuff. Okay. So again, it also aids in a very accurate handover on that patient's behalf of any potential error corrections. A good example of that would be, I've had nurses tell me, hey, the IV fluid, 0.9 normal saline, it's running at 125 milliliters per hour. And you go in the room and you're looking at the pump and it's going at 100. And you're like, well, wait a minute, you said this rate. Why is it going at that rate? Oh, you know what? Oh my God, I'm so sorry. I saw the order. I got a phone call from a family member. I gave them an update. I thought I had changed the pump. I didn't change the pump. And oh my goodness, I did not know it was running at the wrong rate. See, again, since you're at the bedside, you're seeing that, together with the other nurse. That gives that the nurse is about to leave also an opportunity to fix her error. She fixes that and then she can update her documentation that in the computer system she wrote down is going at 100 an hour or 150 an hour. And it may be the other Okay, so she can now update it to what the right rate was, and make even a note. Just change the IV fluid rate to this amount at such and such a time during change of shift. Now Diane is taking over the patient's care. Blah blah blah. Okay, that doesn't leave you in a bad situation where you walk in the room, you were told something else outside the room, and then you're like, oh my God, was this going at the wrong rate the whole day? Was it just a couple of hours? You're guessing, and you're not going to possibly know the answer because you weren't in the building. You were at your house. But that gives that other nurse a chance to rectify the situation and explain what happened and actually fix her documentation as well. Yeah. Because whether that patient is a dialysis patient and only can get so much fluid per hour, and this nurse, the previous nurse, has all this fluid pumping into this poor patient, tons of fluid, when the order says to drop the rate down. Now you're taking responsibility for something someone else did because you didn't get bedside report, and now the blame is on you, and you don't even know when this occurred, how long it happened, etc. Bedside report covers your butt. It also helps the nurse that's leaving cover her butt and fix whatever errors she may have made and fix her documentation, but it also helps the oncoming nurse, and it also helps the patient too, so the patient can put their spiel on what's going on with their care, or if there was a misunderstanding because the patient didn't press the call bell all day, and the nurse is saying the patient wasn't in pain, the patient really was in pain. Okay, so many reasons why bedside report is important. I'm going to end it with this question because I do want to share a story with you. It happened in my second year of nursing, and like I said, I've been nursing for over 2 decades, but I think it is huge. This is not something I've seen again since then, but who's to say if other nurses may have seen it? If you have seen what I'm about to say, please feel free to leave it in the comment section. I'm really curious about your experience. Let me tell you the number one reason I feel bedside shift reporting is important. Okay, so 2 years into nursing, I come into a hospital. I'm not going to say the hospital's name. I'm not going to say the nurse's name. Not going to say the patient's name. I'm not going to say what type of unit it was. Well, I can say the unit. The unit was a telemetry unit, PCU, progressive care. Okay? And it was a total care hospital in terms of they only did RNs. They did not hire CNAs at the time. They believed in total care. Even though other hospitals had CNAs too. So anyway, the situation was the nurse wanted to go home. She had a long day. She was running late for some appointment she had to do. I don't know if it was taking her daughter somewhere or whatever it was. And she's like, look, I know we're supposed to be doing bedside shift reporting, but I'm really in a rush. And sometimes the patients, they interject a little too much and it's going to take up a lot of time, et cetera, et cetera. And I'm like, look, I've only been a nurse for, roughly 2 years, and I feel more comfortable if you do bedside shift reporting. I'm still learning and growing. And let's just do it at the door as opposed to going all the way in the room. So that way the patient can see me. I can wave in there and say, hi, Mr. Smith or Mrs. Smith or whoever. I'm your nurse for tonight. Your nurse, this is your nurse here. And your day shift nurse is giving me a report on how the day went. And once she's done, I will be in to see you at the bedside in terms of your vital signs, doing your head-to-toe assessment, etc., discussing the meds you're going to get for this evening, etc., etc., because I was night shift on that particular shift, and she was day shift getting ready to leave. So she agreed to that, and I was able to poke my head in and say those things. She was able to give me a report at the patient's door. Technically, we were still in the patient view, so the patient could interject if they wanted to. And then if I wanted to quickly run in and look at the IV pump to make sure it was going at the rate she said, I could dart in there and do that. But that's the only exception I was willing to make because I still want to see my patient. Okay, so to just get to the main spiel of what happened, oh my God. When we got to patient number 3 of the 6 patients she was giving me, I stuck my head in. I said, hi, Mr. Smith. I'm your nurse for tonight. Your nurse is giving me a report, and I will be in there shortly to do your vital signs and your head-to-toe assessment, discuss your meds, etc. The patient's eyes were open. The patient did not turn towards me, did not respond to me. And I'm like, oh my God. And I run in the room, and the patient was dead. Now, keep in mind, this is a telemetry unit, PCU, progressive care. Why is that important? It's important because the patient was supposed to be on a monitor. 5 little electrodes on their chest, hooked to 5 wires. And the person that's watching the monitors, at the time we had a monitor tech that was hired to watch monitors. They should be saying, hey, the patient is asystole, the patient is sinus brady, sinus tach, sinus rhythm. The patient has a beat, a heartbeat. So I don't know what happened. I don't know if they had overhead paged and say, hey, nurse, could you check your patient? The leads are off, or I'm not getting a rhythm, because a lot of times they'll do that because the monitor tech cannot get up from that station and go check the patient themselves. They may overhead page, hey, can someone go into room XYZ and check the patient? They won't say the patient's name overhead, but they will say the room number because I'm not getting a reading on the monitor. That could have just happened. I don't know. Because again, I'm coming in from home and that person the nurse has been there all day. But yeah, patient was dead. So of course I quickly called the code, and the charge nurse ran in and was like, okay, everyone hold off. This patient is a DNR, which means DNI stands for do not intubate, and DNR stands for do not resuscitate, meaning the patient does not want to have CPR done. The patient does not want to be intubated by a machine to breathe for them. It is against their wishes. And they assign paperwork to say so, that if they should ever pass, they don't want you doing anything to extend their life, okay? So we end up, even though someone came with a crash cart so we could start the code, we end up not doing the code because it was against the patient's wishes. And of course, we notified the doctor, notified the family, etc. But my point is this. What if I had listened to that nurse and did the report at the station, the desk, the nursing station desk, where she wanted to do it, nowhere near the patient's room? I would have walked in there saying, oh my God, did this patient just die? Like on my shift as soon as I got here? I don't even know how long the patient had been gone. But that happened on her shift during her watch. And of course, she had to document that in her notes and take account for that passing and be responsible for calling the patient's family, et cetera, et cetera. And of course, I helped out, but either way, it was still counted on that person's shift and should it be documented on her shift, since we noticed that it changed the shift, but the patient had already passed. And that's really kind of morbid and sad, but I say this to stress the importance of bedside shift report. And I say this especially too for the seasoned nurses that may be listening to this video, because a lot of you guys don't want to do bedside shift report. And maybe you haven't had a horrible experience like I had in my second year of nursing, where I walked in with that nurse and the patient was dead, okay? So very important to do bedside shift report, okay? Okay, guys, I hope you got a lot out of this session and learned something new, or at least had your memory refreshed on some things you learned in school. So again, go ahead and like and subscribe, and definitely share with coworkers, share with other students, share with people that just want to know what's going on in the hospital. Share with someone who you think may be going through some type of abuse, whether it's physical, emotional, psychological. This can help many people, not just nurses or nursing students or med students or new doctors, etc. This can help a lot of people, this particular session. So definitely share. And if you have any questions, whether it's personal, whether it's related to school, whether it's related to abuse, whatever, you can feel free to reach out to me on my email. The email is SkillSnacks, YT for YouTube, at gmail.com. Again, SkillSnacks, YT at gmail.com, and you see it is up on your screen. Okay, you guys have a wonderful day, and I will talk to you next time.